All right. Hi, everybody. So I'm Christy. I am again, voice therapist and somebody with ADSD. And so the last two webinars, I focused a lot on voice therapy strategies for managing and compensating for symptoms of SD. And today I really wanted to kind of shift gears a little bit into talking about the psychosocial symptoms and quality of life effects of SD. And for me, this is a very important topic and one that I feel is not often talked about as much as the actual direct voice symptoms. So I wanted to delve into that a little bit today. And I think this can be especially relevant right now, especially when a lot of individuals are struggling to get treatment. These kind of psychosocial symptoms can be even more relevant and apparent right now. And so just a little bit of background, SD is typically characterized by its physical symptoms, so the voice symptoms themselves, so the strain, the roughness, the breaks, the breathiness and effort. And, the management is based on kind of this medical model of also looking at these voice symptoms. And so clinicians will kind of assess the sound quality, look at how the voice is sounding, and then possibly use a VHI as kind of a measure of voice handicap for the participant. And then the gold standard of treatment right now is still botulinum toxin, Botox injections to minimize and focus on those voice symptoms themselves. And so, I want to ask the question, well, what about beyond those voice symptoms? And so what about the actual full impact of the voice disorder and the quality of life impact? So this would entail these psychosocial symptoms of emotional distress or high emotions, the loss of a job, reduced social participation, inability to participate in daily tasks, avoidances, negative thought patterns, relationship changes. It can kind of span a lot of domains of a person's life. And I think this can look very different from person to person, and depending on their coping strategy, their personality, what stage they're in of the disorder, what treatments they have, their support network. So there's many factors that can affect how a person is kind of affected by these psychosocial symptoms. And I think it's important to note that these symptoms can also be apparent at any stage. So, maybe before the diagnosis phase. So, before you even get that that name to what you're dealing with is quite frustrating and confusing. And, the diagnosis itself can lead to a whole host of emotions. For some, it can be relieving, but for others, it can, on the other side, kind of lead to confusion or, difficulty accepting it, or even difficulty understanding what that means long term or what the disorder even is. And so then kind of there's the journey of after the diagnosis, what does that mean in terms of dealing with it for the rest of your life? And how does that journey look, and what psychosocial symptoms or quality of life effects are present? So I think individuals who are not getting treatment can have psychosocial symptoms, but individuals who are getting treatment can also have psychosocial symptoms. And the treatment itself, I think it's important to note, can bring up some of these psychosocial symptoms. So just because a person is getting treatment does not mean that they're not dealing with any symptoms day to day. So their symptoms can still be of these psychosocial symptoms. So perhaps somebody's getting, the botulinum toxin, Botox injections, but it's, and maybe it really works well for them and they have their dosage down, but maybe it's still that side effect period that's really bothersome or frustrating or impairs their ability for 2 weeks to do their job. Or maybe it's the cost of them, or the fact that somebody has to travel far to get them, or take off, work, or plan, work or personal activities around the Botox injection. And it's temporary. There's that need for kind of repeated treatment every about 3 to 4 months, maybe, for somebody for the rest of their life. And that can get pretty exhausting or take an emotional toll as well. And, surgery can come with its share of psychosocial effects. And so there's the anxiety and fear, and, what if it's not completely permanent? And voice therapy is kind of the least invasive of all of these, but also can, bring up a lot of kind of psychosocial effects. And, you're really dealing with a lot of frustration there too, and facing that head on, and trying to address any barriers to treatment in terms of, self-efficacy and your motivation to stick with it, even though it's kind of this kind of up and down, and you're going to have those obstacles. And I think Caroline Ziegler who's a speech pathologist, did a lecture for the NSCI symposium, and kind of really described this very well, of that, in voice therapy, you're really facing yourself. And I think that's very true, is that kind of, you're overcoming those barriers, but that takes time and a journey in itself. So I think it's important to look at these, like I said, to try to individualize treatment. So if a person is getting significant side effects from their Botox injection, for instance, we would want to look at that and know that in terms of how to plan their next dose. And so if, the side effect period is even worse and they're getting it for 3 weeks of breathiness, that could be even more impairing than the voice symptoms themselves. Or, perhaps the Botox is just really not effective, and we need to maybe look towards something else, like voice therapy, or something like surgery for that patient. And I think it's important to know, voice therapists and speech pathologists, we do counsel patients in this, in the functional aspects of how it's affecting their quality of life. But, we also would want to know when the psychosocial symptoms are really just so weighing on a person that we might, as professionals, want to refer out. So that would be social worker or mental health therapist who can help the person appropriately deal with these, valid and normal emotional or psychosocial effects. So I want to bring up this image here, which is actually an analogy, an image that is depicted often for stuttering. And so for me, I love it because I find it very relevant to spasmodic dysphonia. And for me, it's something that I can highly relate to myself, but also, find it true for the individuals I've spoken with SD as well. And so the analogy is that there's this kind of iceberg, and you only see part of it, right? You only see about, 10 or 20% of this iceberg, which is above the surface. And so that's the stuttering itself, or in the case of SD, that would be, the actual voice symptoms themselves. And then you have this whole portion underneath the surface, which is all these emotional or psychosocial effects. So the fear around it, the shame, guilt, anxiety, hopelessness, isolation, or denial. And I think these ring very true often for someone going through the process and journey of dealing with SD as well. And so, we often don't even look at these, and often it's only that 10 to 20% that's really, treated. But we know with stuttering that we can't fix the problem itself. So we can't actually cure stuttering. So the goal of speech therapy actually with stuttering is to not get rid of the stuttering, and to make sure that somebody knows going into therapy, speech therapy, that that's not the goal, because we can't. And that's the same thing with SD, right? We can't take it away. We can't cure it, but we can certainly give the person with a stutter or person with SD lots of strategies to compensate in more efficient ways. But then, in stuttering, it goes a step further, and really the stuttering speech therapy is built around and based around minimizing these psychosocial effects. So it really focuses on getting a person who stutters to be really comfortable with their stutter and really open about it and accepting of it, and to decrease that shame or anxiety surrounding it. And so, we would focus on things like voluntary stuttering, where you stutter on purpose to somebody in public and really kind of be okay with their reactions, or educate them in response to that, instead of being really ashamed and trying to hide it. Or, reducing the avoidances. So if you're avoiding eye contact or avoiding certain places, we actually, it's desensitization of that avoidance. And you actually, have people go into those more difficult contexts and get more comfortable with that. And so I think, talking about SD, it brings up a lot of similarities in my mind, at least, for, perhaps we can start to look at maybe addressing these psychosocial symptoms more in terms of the acceptance piece, or shifting to really decrease the shame surrounding it or isolation. So I wanted to talk a little bit about, a study I did in 2016 with Celia Stewart, who is at NYU. And we did a survey study, and I think it's, some of you may have filled that out, so thank you so much if you did. I think it's really helpful for not only us as clinicians, but on the other side as a patient, to really, validate these emotions and say, okay, I'm not the, as a person with SD, you can see that you're not the only one that has, these symptoms, and that other people are dealing with very similar, strong psychosocial effects. So we wanted to know what the most prominent psychosocial symptoms were that exist in this population, aside from just the voice changes. We wanted to know what role these psychosocial symptoms play in how an individual is perceiving their handicap. We wanted to kind of look at, well, is the standard measure of voice handicap right now, which is the Voice Handicap Index, or VHI-10, is that really appropriately capturing the experience or the lived experience of a chronic disorder like SD? And then what are the most prominent or most important symptoms for professionals to know when kind of looking at, or when they have a patient with SD in front of them? So this is the sample we looked at. We got 127 participants. The age ranged a lot. We had mostly females, but about 30 males. Age of diagnosis was 11 to 74 years old. We had mostly typical onset, but about almost 30% early onsets. About almost 80% had received Botox injections at one point, and 71% received speech therapy at one point. The current treatment, 41% were currently receiving Botox at time of the study. Almost 40% were actually not receiving treatment, which, in my opinion, is a high number. And then we had a small percentage that were also taking medication, receiving voice therapy, or had laryngeal surgery. And so we had a good mix of people getting treatment and not getting treatment, and the treatments also varied. So when we look at these biopsychosocial categories, we wanted to categorize them into kind of different domains here. So we look at the personal factors, which is, in my mind, kind of the crux of everything, which is the emotions experienced, the cognitive changes, which would be the thought patterns that develop or change as a result of the voice disorder. So the acceptance, the thoughts about one's voice disorder, the thoughts about speaking itself and maybe the actual process of speaking, and changes in self-view or kind of this negative self-talk pattern. And then behavioral changes like avoidances of people or places, and then trying to hide one's voice problem. We have activities on participation, which includes interference of the voice disorder in daily activities, so like talking on the phone or doing work activities. Changes in professional or familial roles, changes in relationships even, and then changes in enjoyment, so possibly decreased enjoyment in activities that the person wants to part in. Then we have the environmental factors, which is really how different communication situations or communication partners affects these different symptoms or makes the voice better or worse. So I just wanted to go through briefly each category and just highlight some of the most prominent symptoms that were revealed. So the M indicates the mean. So we had participants choose a response from a Likert scale from 1 to 5. 1 is strongly disagree, 5 is strongly agree. And so the when the M is closer to 5, the higher the number that number indicates that most participants were answering towards the end of the scale that was strongly agree. So we asked the question, for instance, I feel self-conscious about my voice problem. And you can see that most participants were indicating agree or strongly agree to that, followed by frustrated, annoyed, less confident, and you could see angry, anxious, and anxiety in preparation of speaking. And I thought that last one was very interesting because we often hear of anxiety, but we don't talk about how it's relative to just even in preparing to speak, a person's feeling those strong psychosocial symptoms. For the cognitive or thought patterns, individuals are feeling like they can't express their emotions or thoughts in the way that they want to, which is pretty inhibiting and significant. I think the second one down, being hard to accept a lifelong disorder upon initial diagnosis. So I actually talked about this at the symposium on our panel, and how, my acceptance of the disorder actually was a huge turning point in me being able to actually more effectively deal with the disorder versus feeling shame or trying to hide it. And so I think that's a really important piece that people, struggle to even accept that at the first diagnosis, which makes a lot of sense. It's a heavy diagnosis and a hard or confusing, diagnosis to get. Feeling like the personality changes, or that the voice doesn't represent the personality, right? So if a person is if a person is perceived as being nervous or perceived as being anxious, when really it's just their voice. Believing that strangers are judging them just on the voice. Seeing people's facial reactions, or maybe a person says how they feel about them, or maybe that's just a belief, and maybe those people aren't actually judging them, but the participants with SC are feeling that way. So using the words freely is less, they're less able to do that. And then I think this last one here, rehearsing what I want to say in my head before saying it out loud, is something that, I've experienced myself, and I think it's something that frequently occurs, but it's not talked about really. And, that process of even the anticipation of how your voice is going to sound, or the building up before you even speak, or trying to get a word in a meeting, or, what's going on in your head before you get to order, or right. So that all of that can build up and actually make the voice a little bit worse, because then you have this built up tension. And then we look at these behavioral changes of, really avoidances. So avoiding the the one closest to strongly agree for most participants was, when my voice is bad, I avoid socializing with acquaintances or people I don't know well. So people you're meeting for the first time, that might be a harder situation than people who kind of know you or are more accepting. So in the environmental category, again, this is kind of different situations. People were not as comfortable speaking in large groups and speaking to authority figures. Those were the biggest reported ones. And then, most instances, individuals were evaluating the situation around them and the effects of speaking before talking. So actually weighing the pros and cons of opening your mouth to say what you want to say, depending on who's there, or how your voice is that day, or how loud it is in the background. And I think, individuals are probably holding back a lot and not expressing themselves fully because of this. In the activities and participation, individuals indicated enjoying restaurants, communicating with friends, and speaking on the phone less. The phone is one that we know, and communicating and socializing with friends also makes sense. If it's a lot more effort, it's a lot less enjoyable. Or if they feel like they're going to be judged by people, it becomes almost like a chore or work rather than something enjoyable. And then the voice itself actually interfering with success in work or school, which could be really debilitating and a huge quality of life effect. And so just to look at these voice symptoms themselves, so the majority of participants, almost all participants, indicated strongly agree to the item, I dislike the sound of my voice. And that was actually the highest item out of everything we surveyed, which is not surprising. And then having to think about the process of talking was also pretty high in terms of the mean. So most individuals were indicating that they strongly agree to this, and talking is now less automatic and is more of just a conscious process or an effort. And then we have these typical voice symptoms that we know very well and hear about. So then we looked at these different categories. So the categories I just went through, and we correlated them, or we wanted to see what the relationship of each category was to voice handicap. And so we discovered that the personal category, so personal category here, which includes those emotions, the thought patterns, and the behavior changes, was actually the most related category to how individuals were viewing their voice handicap. And again, we measured that through the VHI. And so that was actually more related to an individual judging their voice handicap than the physical voice symptoms in this body function category. And so we looked at individual survey items, and we wanted to see how related those were to voice handicap. And so we saw that the personal category was actually the most related to the personal category was actually the most so we saw here that hopelessness was the individual item most correlated or most related to an individual's voice handicap. And that's a pretty strong negative emotion here. And that's, almost disheartening to learn, but at the same time, it's good to be aware of this and makes us think, well, what can we do maybe to decrease this hopelessness? Is it more treatment options? Is it, providing individuals with more strategies to be able to have some more hope, or connecting with others in the SD community? And again, helplessness is almost very tied to the hopelessness in terms of an individual feels that they just have no control. And again, I think we can really target that in terms of, from a professional standpoint of maybe voice therapy, giving patients a little more control or modulating their treatment to do that. The belief that others treat them as less intelligent was the third most related to how individuals are viewing voice handicap. And then anger about his or her voice, which is a pretty strong emotion again. Voice breaks was the fifth most related to voice handicap. But there are 4 of these psychosocial symptoms that were more related to VHI than just any voice symptom, any direct voice symptom. So last thing here is that we looked at each category and how they can predict voice handicap in the personal category. So the emotions, behaviors, and thought patterns can actually predict the voice handicap that a person is feeling. And it was a best predictor. So instead of just the voice symptoms, it was actually the emotions relevant, or the thought patterns or behaviors change that actually was best predicting that voice handicap. And so these are just a few of the things that individuals with SD commented. So it's handicapping, it's frustrating, it's hopeless, exhausting, life-altering. It affects the whole being, so it's not just about the voice, and that really hits on what we're talking about today. It's more than just the voice, it's all these other aspects. How it impacts me emotionally, again, speaking to that. My voice does not reflect who I am. Being able to talk is being alive, being a person. And so once that's taken away, it's almost robbing you of life in a different way, or it can feel that way. And while it's a disability, it does not affect intelligence. And then, someone said, speaking with ease is something we take for granted until it's gone. And I think that's so true. It used to be maybe automatic, and then we took it for granted, and now we're really learning the delicate nature of speech. And then this last one really hits home here, the grief and the loss, and the fact that it seriously affects loved ones also. And so it really can be almost a grief or loss process. And, there's a great description of this on the NSDA website in the personal journey piece, and how, you might actually go through the stages of grief dealing with SD of, denial, anger, acceptance, and that those might not be completely linear or in the same order that somebody else might go through them. And it might take a different amount of time. You might kind of go back through some of the stages. But I think that it's very warranted to recognize that it's almost a grief process, that you lose that same ability to speak that you once had. So we know that these psychosocial symptoms are clearly very impactful in individuals with SD, and they're very important. And we know that they exist in those even getting treatments. that these emotional, behavioral, and cognitive effects may be more debilitating than just the voice breaks or roughness. So maybe we should focus on them a little bit more. And then they might not be adequately captured by the VHI because, what we kind of found went a little bit beyond what the VHI actually captures. So, how do we better address these psychosocial symptoms? And, perhaps this can be important in tailoring somebody's treatment. So, minimizing their Botox side effects, um, the need for maybe more treatment effects, which a number of researchers are currently working on. And, I think looking at this here, I wanted to just circle back and look at this kind of iceberg framework. And so the question is really, and so somebody who stuttered actually made this, and I love this. And I actually spoke about this and a few others on the panel that we were at in the symposium, and how, we each kind of had our own journey in shifting, I think, from the picture on the left to the picture on the right. And that's really the goal for anybody, is to, how do we switch these negative psychosocial, feelings to be a lot more positive? And so instead of, the shame, maybe finding acceptance, or, the isolation, find community. And instead of the guilt, finding, kindness, and switching that hopelessness to finding hope, maybe with, a treatment that works for you, or finding a good support network, or others in the SD community. And I think there's a number of resources. So, finding that piece of empowerment or a passion outside of your SD, or shifting, your duties to maybe shifting a career path to something that you love, or something maybe that SD has made you more passionate about in terms of listening, or medical research, or, caring about people, or whatever it is, maybe making some shifts to allow yourself to kind of reframe and to see this. And again, maybe, working with a voice therapist who can help you, or maybe if you're dealing with significant emotions, maybe, a social worker, or somebody who can help you kind of navigate these emotions as well. But again, that self-empowerment piece, I think, is really important, and educating yourself through the NSDA, or, lectures like these can be really helpful too. And so I also posed the question to others of what has helped you most dealing with this disorder. And again, support groups, like I mentioned, the NSDA Symposium and website, Facebook support groups, so being able to connect with others who have it and know that you're not alone. Having a trustworthy otolaryngologist or SLP or voice therapist working with you and, on your side, and somebody who really understands it from your perspective, accepting it, finding humor, trying to find the bright side, having a great support network if you can find that, and trying to decrease life stressors. And so, what we talked about today really highlights how important these psychosocial symptoms are. And, we need to really think about how we're treating individuals to better acknowledge or address these feelings of hopelessness, and support patients in finding the resources that is going to lead from, to that reframing. And, considering voice therapy again to not just target the voice symptoms, but to help a patient navigate, regaining participation in activities like speaking on the phone, or being able to feel more confident when meeting somebody for the first time, and practicing that. Acknowledgement and validation of living with the disorder, that you're not the only one, and that these feelings are normal. So a speech pathologist actually can do all of that with somebody as well, and I think that's an important piece. So again, right now, that's going to look like probably telepractice, because still in-person appointments are not available. But I think, a good SLP who understands voice and chronic voice disorders can work with you on those strategies as well. And then promoting education, not just for yourself, but amongst other people. So, spreading awareness and educating others can be really helpful for the community as well. So these are some references if you guys are interested in any, reading more into all the stuttering literature or the literature that's been done on, qualitative experiences or psychosocial experiences. Here. So thank you so much. I wanted to give a big thank you to the NSDA for allowing me to be here for this webinar series. It's been really wonderful to be able to share with you guys, and hopefully, you can take, bits and pieces that are helpful for you. And thank you to, Kim Kumin, he's the director of the NSDA, for really putting this all together. It's been really amazing to see all the behind the scenes work, and I don't know how she does it, but it's been really, really great to participate here. And, you can always email me with any questions. I'm happy to answer questions. You can also check out, I have a blog at this website here, speakingboldly.com. So if you have any, if you want to see more about my personal journey, or kind of living on both sides of this as the SLP and, as a voice therapist, please feel free to visit there or shoot me an email. I love to connect with people about their experiences too. So feel free to also, connect with me that way.